The title of the presentation is Charges, Complication, and Outcome, a comparison of laparoscopic Nissen Fundoplication versus magnetic sphincter augmentation for GERD. Paper is going to be presented by Dr. Reynolds, please.
Good afternoon. Thank you for the opportunity to present here today. I have no disclosures. One of our investigators does have a disclosure relevant to my talk here today. Gastroesophageal reflux disease affects up to 25% of the population. Nissen fundoplication is this gold standard surgical therapy for GERD. However, due to concerns over side effects such as gas, bloat, and durability, less than 1% of eligible patients seek surgical treatment. Magnetic sphincter augmentation was developed as an additional option for uncomplicated GERD. These patients, despite having severe symptoms, have a fairly normal esophagus with a normally functioning lower esophageal sphincter. It's a flexible band of interlinked magnetic titanium beads that's placed laparoscopically around the GE junction and augments a weak lower esophageal sphincter, preventing reflux while allowing normal functions such as swallowing, belching, and vomiting. Multiple studies to date have shown MSA to be safe and effective for the treatment of uncomplicated GERD with pH normalization, PPI elimination, and symptom control similar to that reported for fundoplication. However, the MSA device itself is costly, averaging $5,000. Patients undergoing MSA often have shorter operative times and shorter hospital stays than patients undergoing Nissen fundoplication. So the aim of our study was to compare hospital charges for the index admission between laparoscopic Nissen fundoplication and magnetic sphincter augmentation, and to look at the outcomes in these patients as well. It was a retrospective review of all patients undergoing MSA or fundoplication over a 3-year period at 2 hospitals by a single surgeon. All hospital charges were obtained for the index admission. Surgeon charges were not included. First, we looked at preoperative characteristics. And other than more males in the MSA group, there was no difference in any of the preoperative characteristics that we looked at, including pre-op GERD HRQL, hiatal hernia, laryngopharyngeal reflux, preoperative dysphagia, Barrett's, or esophagitis. Next, we looked at charges. Total charges were the same for MSA and fundoplication. And although total billable supplies, which includes the MSA device, was higher for MSA, this was offset by higher charges for fundoplication in nearly every other category, including pharmacy and drugs, labs, test radiology, OR services, and room and board. This was driven by a longer OR time for fundoplication and a longer length of stay of nearly a day for fundoplication. Next, we looked at our outcomes. We had 1-year follow-up for 92% of our MSA patients and 88% of our fundoplication patients. GERD HRQL scores and PPI use was similar for both groups, and there was no difference in the amount of dysphagia or the number of dilations for dysphagia between the two groups. MSA patients did, however, report significantly less gas, bloat, and inability to belch and vomit. Patients were equally satisfied, and most patients in both groups would have the procedure again. Lastly, we looked at complications. There were 2 30-day complications, both in the fundoplication group. 1, readmission for intractable vomiting on post-op day 2, and 1 with food impaction at the GE junction requiring endoscopic removal of the food bolus. There were no MSA device removals or erosions, and no fundoplication reoperations. So the charges for the MSA device are offset by a decrease in all other hospital charges due to shorter operative time and length of stay. There's no difference in efficacy or safety at 1 year that we found, and no difference in dysphagia or dilation for dysphagia. There's a higher ability to belch and vomit after MSA and less gas bloat symptoms. So MSA is a cost-effective option for the treatment of uncomplicated GERD with equivalent charges to fundoplication, equivalent outcomes, and fewer side effects. Thank you.
Paper is nicely presented. Paper is open for questions.
Jerry Redan from Celebration, Florida. Thank you very much. It's very nice. Our experience has been much different than yours. And just, first of all, I'd like to know why you think your length of stay is so much longer for an uncomplicated Nissen, and I'm assuming they're uncomplicated Nissens. And one of the big challenges we have had is we can't get insurance authorization to pre-certify, since our cost essentially is $5,000 for this links, and only about $1,000 for a couple trocar stitches and maybe an energy source device for the Nissen. I was wondering if you have any thoughts on that.
So I'm sorry, what was the first part of that again? Length of stay, yeah. So our fundoplication patients, just in general, stay overnight usually until they're able to tolerate a diet and their pain's well controlled. So for most patients, that's anywhere from 24 to 36 hours, whereas our MSA patients are discharged from PACU, sometimes as early as 6 hours post-op, eating a regular diet on oral pain meds. So that's really where the nearly day difference in length of stay comes from. So I don't think our fundoplication patients are staying that long. It's just that our MSA patients are staying so short.
Okay.
Insurance? And insurance. So I know we have similar issues at our institution with getting insurance coverage. You know, I don't personally deal with that too much, but I know there's a lot of letter writing, and we are able to get some of those covered. And those that don't, patients either continue on PPIs. Some patients do end up opting for fundoplications. A lot of patients choose to continue on PPIs and continue talking to their insurance company to see about coverage and waiting for it to be covered.
Dr. de Meester?
Nice presentation, Jessica. She's my current resident, so she knows who I am. Oh yeah, now 2 simple questions. Was mesh used in the fundoplication group at all, and if so, with what frequency and what type of mesh, because that would certainly add to the cost in that group. And the second question is, it's interesting that despite, you know, the reported higher incidence of inability to belch, flatulence, the usual things after Nissen, that the satisfaction scores were the same. So how many people really complained about that, and how relevant is that if the satisfaction score is the same?
Mm-hmm. So first of all, regarding the mesh. So as a general rule, we do not routinely put mesh in our fundoplications. I think when I reviewed the data, there was maybe 1 or 2 patients who, because of a very large defect, had mesh, but overall, the rate of mesh for our routine fundoplications is very low. As far as the, sorry, the second part of the question? The symptom, yes. So I can tell you when I administer most of these GERD HRQLs myself, and when I talk to patients, they talk about these symptoms of increased flatulence and that they're bothersome. But then when you ask them, you say, so about satisfaction, and they all do say, oh, but it's so much better than how I was before the surgery. Before the surgery, I couldn't eat anything. I had severe dysphagia. Everything hurt. I had to sleep up on 4 pillows. So yes, now I have this horrible flatulence and sleep in a separate bed from my husband, but it's better. So I think, you know, you're comparing where they come from, this really horrible place, and even though the place where they are now is not good, it's better. And I think, you know, the main issue when we talk about this symptom is people hear about this, though, and there's people out there who aren't pursuing surgical treatment because they hear about these horrible side effects of gas bloat. So even though the people who have been through it may feel that ultimately they're satisfied, there's a lot of people out there not coming to surgery because they're scared of these side effects.
Dr. Swanstrom, you had a question?
Jessica, that is a nice presentation. I have a methodology question for you. Cost studies are kind of their own specific type of research thing, and it sounds like perhaps, maybe I'm wrong, you drew this from the charge master from the hospital, so an administrative database. Did you look into the fact that one of these is a coded procedure and has an established costing and probably contract relationship with insurance companies, the other one's uncoded there, and do you think that might have influenced the charges that were recorded in the hospital? Did you compensate for that, and how many of these were cash pay patients that simply paid because the insurance companies wouldn't pay?
Mm-hmm. So, you know, when I spoke with our hospital administration regarding charges and some of these coding issues, you know, a lot of it was like talking another language, but the best I could sort of get was the charges were not very affected by the coding, that the charges were standardized for everyone. And that's why the best thing for us to do at our institution was to compare charges, because the charges would be the same for every single patient, regardless of the insurance they had, regardless of what they were gonna pay. Now, of course, this means that the actual cost to the hospital is not necessarily reflected here, because the cost of the hospital is gonna be dependent on what the hospital gets paid, and what the contracts with insurance companies are. But we had to start somewhere at some baseline to compare what the difference may be between these two procedures. So for this study, we started with charges because they are standardized for every patient, regardless of insurance, regardless of self-pay. And we do have a significant self-pay population for the MSA device.
Thank you.